be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.
All right, welcome everybody. Good evening. Thank you for joining the Lung Cancer Living Room, hosted by the Go2 Foundation for Lung Cancer. We're so excited to have so many of you here with us tonight. For those of you who weren't aware, I am not Danielle. She is much older than me. It's true, she just celebrated her birthday, and so she's older than me again, briefly for a period of time. And certainly Bonnie is not with us either. They're actually in Ireland as a family for a wedding, and so we do miss them, but I have a sneaking suspicion. We were talking earlier, Bonnie tends to be an early morning person, and I would not be surprised if she's actually online watching. So Bonnie, welcome.
Hi,
we're glad to have you watching, and thank you for what you've started here, because look at this amazing, amazing crowd. So I'm very excited. We'll do a really quick introduction. We'll save a deeper introduction for you later. But joining us tonight, as many of you had seen, Professor Heather Wakelee from Stanford University and Dr. Amy Moore from the Go2 Foundation. Absolutely clap. And again, I'm David LeDuc. I'm the Chief Growth Officer for the Go2 Foundation for Lung Cancer. I've been with the organization for about 4 years now, and in the lung cancer space for about 10. And I'll share a little bit more about my story and how it relates to our topic for tonight around how lung cancer is really shaping the treatment paradigm for a lot of other cancers. The truth of the matter is what's happening in the lung cancer space is really changing the paradigms for a lot of other cancers and what's taking place in the research world. And really it's people like all of you who are participating in trials, who are taking immunotherapy or TKIs or other things, and it's now trickling down into other places and other spaces, and we'll talk about a lot of those things. So that was why I was excited to hear about this topic, and what we're hoping to do is make it a discussion not only about how lung cancer's treatment has really changed the paradigm. There's things taking place outside of lung cancer that look very promising, and there's going to be some learnings there. And then outside of just the treatment paradigm, there's really a lot of things that all of you touched on today that are going to be brand new to people in other cancers. And so part of the thing I want to talk about today is how do we as a community help drive that change and make it to where others don't have to go through this long education process. So maybe it's a bit easier, and the next time someone with renal cell carcinoma sees one of those doctors, it isn't what's testing, and what do you mean a targeted therapy is available, and what do you mean there's immunotherapy? Hopefully our knowledge will trickle down and share. So that's kind of the basis and genesis for this. And with that, I'm going to turn it over. And traditionally we used to kind of introduce and read the bio, and we've gotten away from reading the bio for this. And so what we've done now is ask the moderators and our panelists to kind of introduce themselves and tell us why lung cancer is important to you, and then we'll move into the dialogue between you and Amy here, and you guys can take it from there.
Great. Well, it's always great to be here and to many familiar faces and a lot of new folks. And so first, just want to thank you all for being willing to share your stories. I think the lung cancer remains something, and I think cancer in general, it's a private thing to have cancer. Some people are able to then make it more of a public thing by making it more public. It helps many other people as well. With lung cancer in particular, there certainly is a stigma. Nice to see that sort of changing a little bit. but there's still this issue of when someone's diagnosed with a serious illness, it can change the relationship with so many different people who are in your lives. And I think that's one of the reasons people are often a little afraid to talk about it. They just, most people, I just want to still be me, even though I happen to have this illness. And that's something really talk a lot about with my patients. And to be able to be here with so many people who are willing to speak out and, be a part of the bigger lung cancer community is always very inspiring. So thank you all for being willing to do that and to talk about being part of the work in DC and raising the voice even louder about it. So I've been treating lung cancer. I'm not necessarily going to disclose my HR, but so when I started in medical school, I knew I wanted to be an internal medicine doctor, and then I realized that I really wanted to be an oncologist. And the inspiration for being an oncologist was the inspiration from the patients I met when I was going through that rotation, and how so many people, once they had the diagnosis, were able to live life a bit more fully. And I know that, for those of you who've been on this journey for a while, I think many of you probably understand what I'm talking about. And for those a little bit newer, sometimes it's like, what do you mean? But it's this ability to sort of, when so many of us go through life just sprinting because there's so much, we're always worrying about this, worrying about that. And when you have a cancer diagnosis, it really forces you to sort of step back and say, I'm live right now. What's important, what's meaningful, and how do I make sure I continue that focus on that, even though I've got this huge issue to deal with that I never really expected to have to deal with. And so for me as a medical student, meeting people who are able to grasp that and really live, I found really inspiring, and also inspired me to want to help the patients who were struggling with that and not quite able to see that side of it a little bit more. And so that was something that I've carried with me since medical school. At the time, I didn't know I wanted to be a lung cancer specialist, but I knew I wanted to be an oncologist. And once I graduated from medical school and started off at Stanford, I think they knew I wanted to be an oncologist. So my very first day, I was on the oncology inpatient wards in the hospital. I showed up a little late because they gave me the time wrong, but we got over that. And I really felt like, wow, this is really what I want to be doing. These are the people I want to be helping. And it's also the community of people who are taking care of patients living with cancer. Some of it's physicians, but nurses, now advocates. There weren't as many advocates back then. It wasn't something people thought about as much, but sort of the whole team, all the people working together, just most people going into that field, it's just really good people, and so it's a great environment to be a part of. And it was in my oncology training that I realized lung cancer was what I really wanted to work on. And back then, we really didn't have a lot to offer. We if you found it early, there was surgery. And at the time, if someone had surgery, we didn't do anything after. We didn't know that we could help more people be cured with chemotherapy or any other treatments. And if someone had metastatic disease, we really just had chemo. We didn't have targeted treatments. We didn't have immune therapy. That was all there was. And so it was this realization that, wow, this is a group of patients that really needs more. They need more help. And it was something where I felt like that was an okay fit for me. And there also wasn't anyone focused on it at Stanford at the time. So it gave me a chance to build up a program so that we could offer trials to patients who came in with any kind of stage of disease. And at that time, it was just all lung cancer. We didn't even separate it out by adenocarcinoma versus squamous carcinoma. I mean, we had small cell and non-small cell, and that was it. And then we had the chemotherapy. So it was definitely a feeling of like, wow, there's so much that we need to be able to do to offer to these patients who are dealing with this illness. And also, like I said, there really weren't a lot of people as excited about it, but I had an opportunity to go to some conferences, and I was able to meet other people working in lung cancer. And at the time, because we didn't have a lot of exciting things to do, the people in the field were really dedicated to helping their patients with the disease. And I realized this was my field when I went to, fortunately invited to be part of a conference that happened to be in Hawaii, so that part was nice. But I realized that I actually wanted to be in the lectures and not out on the beach, because it was really interesting to hear what others were doing to help people with lung cancer. And then things got really exciting. So that was my foray into it, and I was able to really build up the program at Stanford. And now I have 6 wonderful colleagues who are medical oncologists. We've got 5 surgeons and radiation oncologists. You've heard Dr. Neal's name come up a few times. He is coming here in September, and he's fabulous. And Dr. Prado, Dr. Ramchandran, Dr. Das. It's a great team. And so wonderful people that I'm working with, and then wonderful nurse practitioners and nurses, and I mean, just a whole group of folks. But we also now have so many more things we can offer to our patients. And so I remember kind of first learning about these drugs, this EGFR targeted drugs, and going to the first presentation with the drug gefitinib, also called Iressa. And at the time, we didn't know about the EGFR mutations. We just knew that these drugs, if you gave them to people, about 10% of lung cancer patients had phenomenal responses. It was like, wow, that's great. And so we were trying to figure out, can we give this with chemo, and looking at it in other cancers, so colon cancer, different diseases. And then this papers came out showing, well, actually, the reason that this certain percentage of patients respond is because if you test their cancer, you can find a mutation, a change in the DNA in just the tumor, but not in the rest of the person, in the EGFR. And if they found that, those are the people that responded. And if you didn't, those people didn't. And then there was this IPASS trial where, based on the earlier information, that this 10% of people, and the 10% happened to be mostly people who hadn't smoked, who got lung cancer, and happened to be, at least in the earlier trials, more Asian and mostly women. And so there was a study done comparing this drug, EGFR drug, versus chemo in a group of patients who were non-smokers. The study was done in Asia. They happened to mostly be women. And the results came out, and it was kind of confusing until they went back and did the testing and separated out. This is the group that has the EGFR mutation, and this is the group that didn't, but happened to have all those other characteristics. And when that analysis was done, it was really clear that if the mutation was there, it was much better to get that EGFR-targeted drug versus the chemo. And if you didn't have it, it was not a good idea to get the EGFR drug. And so that was when we just shifted the way we thought about lung cancer and decided, oh, okay, we have to test. Because I need to know if someone has this EGFR mutation, because that's how I could best help that person treat their disease. And so that was that really changed the way we thought about treating lung cancer. Now, in other kinds of cancers, they had already known about that, but for very small numbers. So there were some of the liquid cancers, they knew about particular mutations that were found every single time there were particular, like CML. That if someone had this kind of chronic leukemia, CML, they almost always had the exact same mutation. And so that was one of the first things that we could target. So that was really, that made sense. And in lung cancer, we realized, well, okay, we can find this specific gene mutation in about 10% of all cancer patients with lung cancer. What about that other 90%, right? And that really then started the wave of understanding. So then in 2007 was when ALK was discovered. So ALK stands for anaplastic lymphoma kinase. So it's actually not just in lung cancer, it's actually in some other types of cancers as well. But researchers in Japan figured out that in like 5% or so of lung cancer, you could find this one gene, ALK gene, and then we learned what we did from EGFR, so is it the same in ALK? And sure enough, if you give an ALK drug, it's better than chemo, but you have to know that ALK is there. You can't just guess. And now, when we talk about it, it's not just EGFR and ALK. There's ROS and NTRK and BRAF and HER2, and the list goes on and on and on. And I was just in a meeting today with some of my colleagues, like research meeting, looking at, what we call we draw like a pie chart, right? And we kind of slice it up for the different mutations for the probability of finding one within any person with lung cancer. And when we first learned about EGFR, that was only 10%, so we had 90% when we didn't know. And then we added an ALK, and that was another 5%. And now we have about only about 30% where we don't know. Now, some of the ones we know we can't always treat, but just at the American Society of Clinical Oncology, ASCO is our biggest meeting of the whole year. And there was some really exciting data about one part of that pie called KRAS, where we didn't have any treatments that worked before, and now we finally have the first drugs that are actually showing some activity. So it's sort of like that pie keeps, the parts that we don't know what to do, that keeps shrinking. And so that's the whole targeted treatment, and it's really exciting. What's also been exciting is when you start with the targeted treatment, it helps, and I think many of you shared your stories where it was working for some people a long time, for some people not as long. And then we talked about, well, if one EGFR drug stops working, then there's a different one that can work some of the time, but not always. And with ALK, there's 5 drugs. With EGFR now we have 5 drugs. With ROS, there's a couple drugs. The NTRK, there's a couple drugs. So we keep sort of adding to as we understand, well, when this drug stops working, what do we do next? And now we're also talking about adding chemo back in with the TKI drugs and anti-angiogenesis. So but this is the targeted world, it's constantly evolving in our understanding of it. And so that's been really exciting from a lung cancer perspective of being able to be part of the research, but also more importantly, being able to help people specifically once we can understand what's going on with their tumors.
There's a lot to unpack
That's what I was thinking too. By the way, when we were talking about this topic, we were like, there's no way it's a 2-hour topic. There's no way this is like a 4-day
come on,
conference.
you know I can talk.
Yeah, this is like a 4-day conference because there's so much here, because it really does touch on screening and early detection. Why are people getting it? That can be done across tumor types to try and figure out those commonalities where immunotherapy and targeted therapy go next. There's so many, but I know you had some questions that you want to pose or some thoughts too.
Yeah, I mean, I want to kind of back it up to the first topic you addressed, which is targeted therapy.
Yeah.
And it was exciting to go to ASCO and hear, the advances that are occurring in that space, and in particular for KRAS. I mean, that is a major advance in the field. But we heard data on new drug for ROS1. We heard updates on studies for RET. So the reality, I think, is that targeted therapies are extending, improving, saving lives.
Right.
And now we have survivors. I mean, this room is filled with them. People who are living and doing well, and now have a seat at the table for driving research forward. And I think that's been an area where we have, had a lot of productive and meaningful relationships working with patient groups to, interact and have that dialogue to inform meaningful research. What's research that will advance the field? What's research that helps patients? And, just had a call today talking about how all these groups are coming together and uniting.
Yeah.
And so I also had a conversation with Dr. Karen Kelly yesterday, just talking about the opportunity for kind of real world trials and engaging with patients on that front. And so we were thinking about what are ways that patients can be involved. It's certainly going to the advocacy summit, participating in our lung cancer registry. There are so many kind of easy ways for patients to be part of the solution now. What are your thoughts on, how that's working, how, we are seeing that in lung cancer, I think in particular, as we keep carving that pie into these different pieces, that each of those groups is really getting engaged. And how do you work with patients in your own research? Are you actively working with them?
Yeah, so lots of questions in that, right?
Yeah.
So lots of questions. So I'm gonna, the first part I wanna address is about the key role of patient and patient advocates, right? And I think it's, and again, to commend all of you for being here today, because it's about the awareness of the disease, about, there's the sort of the social support for people who are newly diagnosed and not knowing where to turn for information and not knowing what to do, and that feeling of hopelessness that many people have, and say, oh, wait, you also have this disease and you're doing okay, and maybe I'm gonna be able to be okay too, and this is someone I can trust because they're going through the same thing I am, and they're hopefully not talking in medical jargon, and they're helping me to make sense of it. Now, you have to be careful too, because there are gonna be nuances that might not be as well understood, but just to know that there are other people on that journey also is so critical. But then it's also taking what is known and being able to get it out there to people who maybe aren't here in the Bay Area, where we're surrounded by academic medical centers and where everybody knows to get at least 2 opinions, and to ask. But for someone who's in a remote place with an oncologist who is doing their best to stay up on everything, but they're having to know 20 different diseases. So they might not be able to be right there where, I'm very privileged that I can just narrow in on, just a couple of diseases, and so can really be an expert in that. But no one would want to come and ask my advice on breast cancer, because that's not something I do all the time anymore.
Right.
So, to be able to have advocates and support networks for people who are in the middle of a small place and can say, I just got this diagnosis, I'm so overwhelmed, have a network to reach out via the, it's so great having the internet and having ways that people can communicate about this knowledge. And also to give people a voice to advocate for themselves. So the testing, right? We talked about targeted treatment and how exciting it is and how many new treatment options we have, but if a tumor doesn't get tested, you don't know what's going on, and then you don't know how to help the patient the best way. And there's still a lot of places, some not even that far away, where the full testing isn't being done. And so I think that the patient advocate groups especially have been such a critical voice in raising that awareness and really pushing to tell, make sure people know this needs to be done. We're not able to give the best possible care to patients unless the patient knows what's going on with their tumor. And they're not going to know what's going on with their tumor unless they get the testing. And so to raise voices as advocates, as patients, as people living with this disease is often heard far more when it's just the doctor saying we have to do this testing, right? Because then they, well, yeah, of course you want to do the testing, right? But, it's like, no, we really need to understand how we best help people, right? And so that's been such a great thing. And I think one of the other really critical things that's happened with all the strong advocacy voices is that the stigma of lung cancer is reducing, right? It's still there.
Right.
You still have patients where, I hear the story, they tell someone that they've been diagnosed, and instead of what can I do to help you, they get the, did you smoke? I mean, just ridiculous questions, right? And some of that's that I think it's, people don't want to have to face it as, oh my goodness, this happened to you, it could happen to me. So they try to put in a distancing question, which is, often comes out as rather heartless. And then there's also, it's just that many people don't know how to deal with someone who's facing a serious illness, right? It's not just about cancer, it's not just about lung cancer, it's just oh my goodness, you have an illness, and I don't know how I'm gonna be able to process my own emotions around that, so I'm just gonna leave, right? You see that sometimes. So these things come out, and I think by having people open to talking about their illness and about what's going on and about how they're doing, it enables other people to talk about it, and also helps, I think, people see, I'm still a person, I just happen to have this illness, and I can find other people where I can still have that normal kind of conversation where I'm not being seen as just the person with cancer. And I think by raising that awareness and doing programs like this and having people able to talk about it, that is so important also. And then to your other question about, well, from a research perspective, like what's the role there? I think that we really all have the same interest and motivation. We're all looking for how do we best help treat the cancer, keeping the person with the disease feeling as well as possible, right? And hopefully living as long as possible at the same time, right? So that's a common goal that everybody is sharing. And all research is really designed to be doing that. I think where the subtleties come in is how much is this biopsy gonna help the person and the science versus just the science, right? And how much is this extra scan gonna help the person and help the other people who might be then facing the same situation and balancing all of those things, right? Along with the idea of we always need to be thinking about what the patient who's on the trial is the person, right? It's always the patient's always a person,
right?
And how does that person then continue with their life in the context of being part of this treatment, right? And so it's weighing those things, and so making sure if you're in a situation where a trial's being designed and the people designing it aren't as mindful of those issues, making sure that you're getting that voice in there too is really, really important. But it's also having people willing to say, I'm here today because I was on this treatment, which I'm only on because someone before me was willing to do a trial to figure out it worked. Or I'm here today because I was willing to be a part of a study and it worked for me. and also being able to say, I did a study, it didn't work, but this treatment, and then the next thing hopefully will, right? So it's balancing all of those different parts to it.
Yep.
So with all of my patients, try to have at each decision point an open discussion around, these are what we know works, and these are the things that we don't know if they're going to work or not, that we hope might be better, and try to weigh probabilities. But it's always about weighing probabilities, because nobody really knows what's going to work or isn't going to work for a particular person. As much as we've learned and as many options as we have, there's still so many things we don't understand about each individual and how they're going to respond to toxicities of a treatment versus how their cancer is going to react and be hopefully treated by the disease, by the treatment, right? So it's the balance of those two things, and there's so many unknowns there.
Oh, I'll be brave if you're brave. I'll be brave, but only if you're brave. And it could be just you and me. We'll be family. Just wait and see. So I will fight if you'll fight. Yeah, I will fight, but only if you'll fight. Oh, we can make it through this like sailors in a tempest. Like sailors in a tempest together. And it could be just you and me. We'll be family. Just wait and see.